Look my picture. This is my picture. Never mind lah. No, I forgot. Never mind lah.
Sir, please start the session, sir. Sir, please start the session, sir.
It's time to start now?
Yes, sir, please start.
Okay, thank you. Good evening, morning, good afternoon, dear colleagues. Thank you for joining the first ever ASIASAFE AOSR IAEA webinar. Is on AI in radiation safety. The AOSR is the Asian Oceania Society of Radiology, and the IAEA is the International Atomic Energy Agency. AI, as you know, has spread to all aspects of life, and there's no exception in medicine, and radiology being the most computing intensive of all the clinical specialties. There's no wonder it's taking the lead in AI application. And one of the most important concerns of radiology is image quality and radiation safety. So this webinar will be focusing on AI in radiation safety. And we are very happy that we could collaborate, have a combined webinar, ASIASAFE, AOSR with IAEA. And we invited two well-known experts, a medical physicist, Professor Habib Zaidi, and another renowned radiologist, Professor Tchoyoson Lim. Professor Habib is from Geneva, while Professor Lim is from Singapore. So let's begin now by inviting Dr. Evelyn Ho, the president of the AOSR, to say a few words to welcome you.
Hello, welcome everyone to our ASIASAFE IAEA joint webinar. Today's theme is AI in radiation safety. So very often we are focused only on direct, clinically related interpretive lectures and talks. We are also thinking of artificial intelligence more often in ways in which it can alleviate our stress of having many studies to interpret and thousands of sectional images. When can AI give us respite in the face of increasing burden of images and reduce burnout? There is no denying this is important. However, we have a responsibility to our patients to give them the best care that is safe, as well as appropriate and justified. Safety is not expensive, quoting James Hallinan from one of our previous webinars on MR safety in January this year. Whilst not directly revenue generating, we should advocate and lobby our employers and management to ensure they look upon safety issues seriously by taking the proactive step of ensuring radiation safety ourselves. Therefore, AOSR is happy to be able to have IAEA through Dr. Ola Homburg, Head of the Radiation Protection of Patients Unit in the IAEA, and Professor Habib Zaidi for this very timely webinar, which looks at what roles AI could play in radiation safety, and having Dr. Tchoyoson Lim give us the radiologist perspective. We hope you will enjoy and benefit from this webinar. Please fill out the feedback form and look for that link in your chat box and submit it to get a certificate of participation if you need one for claiming CME or CPD activities, or even just for your record. The webinar will be available for review on our AOSR Vidocto platform for up to 2 weeks. Please help us improve the delivery of our AOSR-wide webinar. So feedback. Thank you very much for spending your time with us.
Thank you, Dr. Winnie Ho, as the president of AOSR. I'd like to invite Dr. Ola Homburg, who is the head of the Radiation Protection of Patients Unit at the IAEA Vienna. So there'll be a recorded message from Dr. Holmberg.
Hello, my name is Ola Holmberg and I'm the head of the Radiation Protection of Patients Unit at the IAEA, the International Atomic Energy Agency in Vienna. It gives me great pleasure to welcome you to the very first webinar under the ASIASAFE AOSR IAEA collaboration. We have an exciting topic today, and we're looking at artificial intelligence and its impact on radiation protection in medical uses. And we have two excellent speakers lined up. Also, we hope to continue this collaboration with the ASIASAFE safety campaign, and we look forward to further webinars to come. I want to take this opportunity to promote the RPOP website, Radiation Protection of Patients website of the IAEA. This is an excellent resource that annually has around 1 million page views, and it contains very useful information and frequently asked questions for both health professionals, patients, and the public. It contains links to resources in abundance, including training material, guidance material, technical documents, posters, recorded webinars, videos, incident learning systems, etc. And it's all free resources. So a sincere thank you from the IAEA headquarters in Vienna.
Thank you, Dr. Holmberg. Now let's proceed to the webinar proper. Let me introduce myself first. My name is Professor Kwan Hong Ng. I'm the chair of the ASIASAFE. I'm a medical physicist by training. It's great pleasure to organize this webinar on behalf of ASIASAFE and the AOSR. The first speaker is Professor Habib Zaidi. He's one of my old colleagues for a long time. He's the head of the PET Instrumentation and Neuroimaging Lab at the Geneva University Hospital. He's also a professor at the medical school, Geneva University, also Groningen in Netherlands, also Southern Denmark in District University where he holds professorship. He is a very renowned medical physicist, particularly in hybrid imaging, where he had played a very important role in the development and the widespread use of PET-CT, and now for several years been one of the originators of the PET-MR. This is a impactful research, PET-MR, how it will bring a lot of changes to management in imaging. Besides that, he is also noted for his research in computational physics in deep learning and in radiation dosimetry. Professor Habib won't be with us live today. His medical emergencies family. So we will play his recorded lecture now. Let's pay attention to Professor Habib. Shrita?
Okay, so good morning. Today I've been asked to give a talk on the emerging role of artificial intelligence in reducing radiation exposure in medical imaging procedures. I have nothing to disclose, but would like to acknowledge actually. So with the financial support of the European Commission under the framework of the Symphonia projects and our associated partners, some of the developments actually carried out in my lab, so linked to this project, which focuses on the use of AI for the development of advanced and realistic computational models in radiation dosimetry calculations in X-ray CT and nuclear medicine were actually developed with the support of this project. So this is not really an outline, but kind of list of topics I'm going to cover. First, start with why do we need AI in medical imaging, and then I will cover the promising applications of AI in dose reduction in medical imaging. So basically, using the items that are listed here, so low dose X-ray CT, path spectrum imaging, image segmentation, and so on. And then I'll summarize this talk and provide future perspectives. Well, artificial intelligence is the ability actually of machines to perform certain tasks which need intelligence showcased by humans and animals. AI was a term coined at Dartmouth College in 1956. And then AI went through a couple of so-called AI winters where progress in the field was criticized and governments stopped actually to fund the research in this area. A major milestone is also in 1997, where IBM's Deep Blue beat the world champion of chess. In 2016, Google's AlphaGo program became actually the first computer Go program to beat a handicapped professional human player. And more recently, 2021, a team that used AlphaFold to repeated the placement in the CASP competition in November 2020, achieving a level of accuracy much higher than any other group. So these achievements obviously are correlated with a number of major milestones in medical physics, including the use of the first LINAC in Stanford in the 50s, so the development of the first position imaging device at MGH in 1954-56, the development of the gamma camera by Anger, thermotherapy by Rockmacki, a number of other major developments, including PET-MRI, CT, the Explore Total Body PET Scanner, PET-LINAC, and so on. There are serious initiatives actually at the European and international level supporting the addition of AI components in existing medical physics curriculum and graduate program, where the AI working group of the FOMP published recently a guideline on curriculum related to AI for the education and training of European medical physicists, and there are a couple of other similar initiatives have taken place in other countries and more worldwide. This is one of the examples actually from recent counterpoint paper that was published in medical physics. So this schematic actually outlines the various tasks within radiology where artificial intelligence implementation is likely to have a large impact. So the workflow comprises the following steps of starting from pre-processing of images after acquisition, image-based clinical tasks, which usually involve the quantification of features, either using engineering features with the traditional machine learning or deep learning, reporting results through the generation of textual radiology reports, and finally the integration of patients' information from multiple data sources. AI is also expected to impact based clinical characterization of objects in images using segmentation, diagnosis and staging, and the monitoring of objects for diagnosis and the assessment of treatment response. And all of these are obviously are being explored extensively by different research groups. So a recent paper, Benjamins and colleagues provided an insight into the currently available AI or machine learning-based medical devices and algorithms that have been approved by the US Food and Drug Administration, or the FDA. They identified 64 AI or machine learning-based FDA-approved medical devices and algorithms, and out of these, only 29, obviously 45%, mentioned any AI-based expression in the clinical FDA announcement. So the graph that you see here provides an infographic about the 29 FDA-approved AI-based medical technologies, and most of these technologies were developed in the fields of radiology, cardiology, and internal medicine practice. So getting back actually to the topic for today, so if you check just the example of combined PET-CT imaging, so the effective dose actually the patient receives from the scalp scan, spiral CT, the PET scan are reported here. So basically, so the scalp scan contributes very low effective dose to the patients between 0 to 0.08 millisieverts. The spiral CT, so which is the low dose CT scan for attenuation correction and mapping, delivers between 0.5 3 millisieverts to the patients, and the PET scan, so depending on the activity administered to the patients, so the average is around 4 to 5 or 6 millisieverts. And then a number of institutions perform also diagnostic quality scan with contrast enhancement at the end. Summing up actually the individual effective doses, so we might end up with an average total dose between 20 and 25 millisieverts. So this number has been reduced significantly during the last years, but anyhow, so there was still a number of concerns actually by the professionals and also by the public. For instance, 70,010, so the CT dose was mentioned, so over 2,000 times in the English language media. What's interesting is that a couple of scanner manufacturers, that were Canon and GE, so published a number of white papers recently, and reporting on development of AI-based CT image reconstruction software that has been developed, deployed in the number of clinical centers. So what you see here is basically the true fidelity on the left side and the ACE by Canon on the right side. So obviously both of them reported major improvements in image quality compared to conventional model-based tertiary reconstruction techniques, and Canon also expanded on this development to include also AI-based reconstruction for position emission tomography. And what you see here is one representative example showing on the left side of the standard reconstruction procedure, including iterative order subset expectation maximization with point spread function or resolution recovery modeling, and Gaussian post-reconstruction smoothing. On the right side, you see the AI-based solution actually, which is commercially available from Canon. And here what you see is basically quantitative assessment. So the standardized uptake value is still the de facto standard used in clinical setting. You see how values actually produced with the AI-based solution, which might be interpreted as kind of improved resolution recovery. So when using this software, obviously we don't know the ground truth because this is a clinical study. So one of the interesting developments actually that I have surveyed, so for the purpose of this presentation, is this development by Shen and colleagues, so push really the sparsity to the limits. So you know that you're familiar with the principles of topographic imaging, which requires a certain number of projection views from a large number of angular positions to be acquired to produce artifact-free volumetric images. And so this scientist from Stanford showed that deep learning models train it to map projection radiographs of patients to the corresponding 3D anatomy can subsequently generate volumetric X-ray CT images of the patients from a single projection. And these are some of the representative examples they have provided in this article, where they demonstrated the feasibility of the approach with upper abdomen, lung, and head and neck CT scans of 3 patients. In another study actually carried out by our lab, so we aimed to design an ultra-low dose CT examination protocol using deep learning approach suitable for clinical diagnosis of COVID-19 patients. So in this work, we used 800, 170, and 171 pairs of ultra-low dose and full dose CT images as inputs and outputs for training tests and external validation tests respectively. to implement the full dose prediction technique, and we use the residual convolutional neural network to generate a full dose from ultra low dose city images. And the quality of the images was predicted by radiologists who assessed basically the images. So we're given scores from 1 to 5, and then we use also a number of quantitative metrics to assess the quality of the images. So obviously we did not scan the patients twice for ethical reasons. So we developed a simulation code that generated the low-dose CT scans from the corresponding full-dose CT scans. And this is one of the examples showing you the chest CT of the one of the patients, full dose. This is the low dose, which obviously increased the statistical noise, as you can see here. And this is the predicted full dose scan with much improved noise properties. So obviously similar to the full dose scan that you see on the left side. And another example here, see the full dose, the low dose again, and the predicted dose. So the same observations can be made with respect to image quality and noise reduction. But what we observed actually from the clinical interpretation of the radiologist is that this is an outlier. And the reason is that one of the COVID-19 lesions, so basically the patchy lesion, was converted to consolidation, and the red rows actually point to these changes in the identified lesion. So clearly this is an outlier where the AI-based solution did not provide the expected outcomes or failed to provide the expected outcome. This is another study, basically, with the busy slide showing the flow charts adapted to assess the additional radiation dose associated with overranging. So major problem actually in X-ray CT scanning. And the aim of this work was to develop an automated scan range selection technique using deep learning to reduce the radiation dose to the patient. So first, the 3D long masks were generated by a neural network, and then the 2D projected localizer images and masks were computed in lateral and anterior posterior directions, and we developed a deep learning method to predict the long masks and the scan image ranges on both 2D images. So this segmentation procedure was developed actually in previous work in the context of segmenting the lungs and the COVID-19 lesions. So we've just used it actually in the framework of this development, the COVID-19 lesion segmentation framework. So the results now, so our scanning was has occurred in 99% and 95% of the cases in the superior and inferior directions respectively. And moreover, so the extent of overscanning in the inferior direction was significantly larger. And the plots that you see here so basically show the additional radiation burden in terms of organ doses in milligray and total body effective dose in millisieverts to patients due to over scanning in both directions. So the evaluation of a large multicentric chest CT data sets revealed obviously a necessary effective dose of more than 2 millisieverts per scan and 67% increase in the thyroid absorbed dose. So significant overscanning also range between 31 millimeters was observed in clinical setting for over 95% of the cases. So by considering the exact lung coverage as a ground truth and AP and lateral projections as input, the deep learning based approach resulted in errors close to 0.008 millimeters and minus 1.5 millimeters in the superior and inferior directions respectively. And more importantly, so this plot shows basically the performance of a deep learning network compared to human range selection, so commonly carried out by the technologies for the outlier cases, and all challenging cases had vague inferior boundary patients presenting with severe pathological conditions. So another study, we used also deep learning techniques to reduce patient dose or acquisition time as the two were obviously correlated. So the objective here was to assess the performance of standard dose or full dose PET image synthesis in the image and the projection domain from PET images and low dose sinograms or projections without sacrificing the quality of diagnosis using deep learning techniques. And the data were acquired in list mode format, which made it easier actually to decimate the data to generate sinograms corresponding to a portion of the acquired data, in this case 5% of the acquired events. And without further delay, so this slide here displays the cross-sectional coronal sagittal views showing the PET reference full dose, low dose, and the predicted images, so in both image space and in the projection space. So the low dose image corresponds to either the injection of 10 megabecquerel of FDG or the equivalent of the full dose that's acquired in very short time, so just one minute acquisition time overall. So the overall conclusion is that these are just the bias maps actually comparing so the reference image with the predicted images and the low dose images, and the conclusion is that the prediction in the projection space produced much better results compared to the predictions in the image space. And this was also the outcome of the clinical validation step for the assignments of scores by qualified or experienced nuclear medicine physicians. So we see here that the scores were close to 4.1 on average for the predictions in the sonogram space compared to 4.47 for the full dose images. And we also performed a quantitative assessments using blunt L1 plots where each data point reflects a brain region. So obviously aligned all the images to the Hammersmith atlas, which contains 83 brain regions, and through the SUV bias is extremely low for the low dose images, so the increased variance compared with the full dose images, and there was observed actually reflecting so poor image quality that was obviously well handled by the AI-based solutions, and obviously the predictions in the sonogram space provided their outcomes. So extended this work actually, because what we did not do in the previous paper is that we did not include the time of flight information, which obviously explodes the data size of the sonograms. What we did in follow-up study that was published in your image, and using so statistical parametric imaging. So what we see here is basically this reduced significantly. So the differences or statistically relevant differences voxel-wise between the predictions in the sonogram space compared to the predictions in the image space. So basically, so confirming the previous results, but highlighting also the importance of the including time of flight information. So encouraged by these results, we pushed this further to a full total body of whole body imaging. And we used also a couple of neural networks, so basically modified cycle generative adversarial network called SciGAN, and the residual neural network, or called ResNet, instead of using synthetic low dose images that we did in the past. So the patients in this case were acquired twice, and the difference between the two, so there is a factor of 8 difference between the full dose scan and the low dose scan. So without further delay, you see here, so basically a representative study with the low dose CT scan, the full dose PET scan corresponding to an acquisition time of 3 minutes per bed position, the low dose scan corresponding to 25 seconds per bed position, and the predictions by the residual network and by the cycle GANs. And then also we asked a number of nuclear medicine physician colleagues actually to interpret so the images, and we splitted the whole body images into 2 zones, so basically focusing on the brain and head and neck area, and then the thorax and the abdomen. Again, so similar to previous conclusions. The quality of the predictions with the cycle GANs was much better compared to the residual network approach. And an additional step that we have conducted in the studies that we asked also our micromedicine colleagues to look to the lesion detectability and to count the number of lesions actually they are seen on both the low-dose scans, the full-dose scans, and the predicted images. And we actually separated the regions according to their metabolic activity. And the outcome is basically what you see here is that cycle GAN missed only a very small number of lesions, so basically 4 compared to 23 for the residual network, and obviously the low-dose scan produced very low scans and missed a significant number of lesions. Just to show you, so one of the examples here, so this is one of the patients with basically clinical study with multifocal multicentric breast cancer with the skin involvement of the right breast and extensive lymph node metastasis, including the mediastinal nodes, comparing the full dose and low dose images, as well as the synthesized images using both networks. What you can see here is that the lesion in the inferior quadrant, so the long red row, was detected on the full dose, low dose, and both neural networks, but the mediastinal lymph node actually that you see with the highlighted or pinpointed with the short red row was visible on the full dose, and cycle was not visible on the low dose and residual network, but was visible only on the full dose and on the cycle GAN. So in a follow-up study, would also focus it in cardiovascular aspect imaging, where we aim to investigate the feasibility of dose reduction in SPECT MPI scans without sacrificing diagnostic accuracy. So deep learning approach was proposed against to synthesize the full dose images from the corresponding low dose images at different dose reduction levels in the projection space. And what you see here is that clinical SPECT MPI images. So for representative studies, we're showing the standard dose scan, the half dose scan, then the 1/8 dose scan, and the prediction, the corresponding predicted images. And the conclusion of this work is that the noise was effectively suppressed by the proposed network, and the predicted standard dose images were comparable to reference dose scans up to quarter dose levels, obviously, so the 8th dose did not produce images that were of diagnostic quality. Another area in which our group has developed some expertise is the development of anthropomorphic imputation models, and this work was obviously done manually, and this took a few weeks to a few months of difficult segmentation work. And the idea here is to automate the process by developing AI-based solutions, and we focused on pregnant patients, where the idea is to develop a deep learning model which is capable actually to segment the pregnant patients, including the fetus, and using a very simple architecture using pairs of X-ray CT images and the manual annotations performed by an experienced radiologist. So you see here the outcome, the original CT images, the manual segmentation in the middle, automated segmentation on the right side of the SCC better on the 3D illustrations here, so showing the coronal and sagittal views of the model generated using manual and automated segmentation techniques. Again, so a very good agreement between the manual segmentation and the automated segmentation performed by the deep learning solution. So our colleagues also in radiation oncology are shifting towards MRI guided treatment planning for a number of indications where the soft tissue contrast provided by MRI outperforms the information provided by the X-ray CT, but X-ray CT is still needed for the radiation dose calculation part. And the idea here is to suppress the need for an X-ray CT and to develop AI-based algorithms that enable to generate pseudo CT images directly from the MRI. And we conducted actually an exhaustive comparison for conventional segmentation approaches or pseudo-CT generation approaches from MRI with a deep convolutional neural network that was at that time produced or developed by Electra, which is a company producing MR Linux, and also other software for radiation therapy, and obviously also Linux. And the outcome of this comparison is that the deep learning network produced much better results compared to conventional techniques reported in the literature. So encouraged by these developments, we developed a method called adversarial semantic structural learning, which contains two generative adversarial cores, one for CT image synthesis, what we see in the upper part, and semantic structure extraction, which is shown here in the lower part. So the CT synthesis and semantic structure cores are composed of a pretty large number of layers, and the network consisted of over 54 million trainable parameters. Without further delay, show you see this the outcome here. You see the MRI in the line of CT and the MRI segmentation procedure, which is implemented on the Siemens PET-MR machine, which basically segments the MRI into single tissue components, actually for the brain if you are in the thorax region. So there is also lung as an additional tissue class, which was not realistic at all. And you see that the deep learning framework provides really very good results. Even the skull is highlighted and depicted here, the nasal cavities. And obviously, if you look to the bias maps on the PET images, so the segmentation, MRI segmentation is not a very good solution for this type of applications. Another framework that has been explored recently is to get rid of the X-ray CT scan and to train a deep neural network actually to transform or to convert the attenuation corrected images directly to attenuation corrected images. And we did this for a number of applications, including neuroimaging for a number of tracers, as you can see here. So comparing here the X-ray CT and the CT-based attenuation correction and the segmentation-based approach that I described in the previous slides. And the deep learning network did a very good job in all four tracers that were explored. And we also explore this type of applications for attenuation correction whole body PET imaging. And the important outcome here is that contrary to CT-based attenuation correction, which might have issues in the case of mismatch between X-ray CT and the PET scan, so the deep learning network is able actually to solve this problem because it's not influenced by the CT, as you can see in this example here. Just for the sake of time, so the largest application I'm going to describe here is internal dosimetry, which is obviously carried out in a clinical routine using simplistic approaches, including the MIRV approach, which was developed in the late 60s and beginning of 70s. And we came up with an interesting approach that enables actually to map the inert depositions voxel-wise. Just for the sake of time, I'll show you a couple of examples here. So comparing the Monte Carlo based approach with the voxel-wise S-values approach proposed by the MIRV and the multiple S-values approach published recently in Journal of Molecular Medicine. And obviously, so the outcome is that the deep learning approach produces much better results compared to the conventional approaches. And similar techniques are being devised also for X-ray CT dosimetry voxel-wise. And this is one of the articles describing these developments, and I encourage you to go through this paper if you're interested actually to explore the power of deep learning for voxel-wise CT dosimetry. And the last thing that I would like to mention here is federated learning, which is an important development in my opinion, which enables basically to pull data coming from different centers without the need actually to get access to the clinical data. So instead of getting access to the clinical studies, so we share the models, and each center is capable to train the model, and then we get back the weights to the server, and then run the A-based solution. And we have used this type of federated learning techniques for a couple of applications, so PET image segmentation and attenuation correction successfully. A number of interesting guidelines have been published by different bodies, including RSNA, radiology, medical physics, and more recently the Society of Nuclear Medicine. These are very important guidelines that need to be followed. Actually, when writing scientific papers reporting on AI-based solutions. And skip again, so the summary for sake of time, and this is the take-home message. So was nice citation by Professor Ingrid Dove. She is from Duke University. Machine learning works quite well, and we don't know why it works so well. So we consider that a challenge for mathematicians to understand it better. And I believe that if something works, there is a reason, and we have to find the reason, right? So with this, I thank very much so my team and the funding bodies actually supporting our research. And I thank you very much for your attention. Thank you so much.
Thank you very much, Professor Zaidi. Amazing. It just totally mind-boggling as we think that CT and PET have reached its maturity, is optimized in terms of dose, and can see how deep learning has further improved its performance in improving the image quality and reducing dose, and lots of fantastic things. Like it's just mind-boggling. Right? Now we like to listen to the other end of the spectrum from a radiologist. Is Professor Tchoyoson Lim, another good old friend of mine. He's from Singapore. He's a neuroradiologist and also a senior consultant at the National Neuroscience Institute of Singapore, the NNI. He's also the adjunct professor at the Duke-NUS Graduate Medical School. Professor Lim is very active in his research, publication. He's very passionate about teaching in medical education, and he also been training lots of radiologists regionally, internationally as well. Because beside his profession as a neuroradiologist, he also has indulged in the computer applications in medicine, and in particular, he's also ventured into artificial intelligence. Now let's listen to Professor Tchoyoson Lim.
Thanks very much, Mr. Chairman, Prof. Ng, for your very kind introduction. I'm going to share my screen. And we heard a very good tour de force by the previous speaker about the reconstruction algorithms boosted by AI. And I will give a slightly different point of view from my own experience, quite biased as a radiologist working with this. This is one of the very first papers that we wrote in IEEE proceedings way back in 2008. In the early work, artificial intelligence didn't yet have deep learning. So in the caveman era, we had expert system classifiers, random forests, and other small data set reconstruction and algorithmic artificial intelligence, as seen here, where we had the idea to detect hemorrhages and built on this until very recently, deep learning blew us all away. And my other claim to fame is this very dubious front page article about losing to a computer and the interpretation of images where the work that radiologists do can be, to a certain extent, augmented or replaced by an artificial intelligence machine, gave rise to a lot of angst and a great deal of discussion in the past few years. So we're hoping to move past that. And today I will speak about what the background of our uncertain relationship with AI is, to talk next of radiation protection plus AI, this combination, primarily described in radiation exposure, not just in CT, where it is growing by leaps and bounds, but also PET, radiation oncology, radiography, and vascular interventional procedures. Then a quick overview of our radiologist's view of not just protection, but safety in AI. My third claim to fame is this article in IEEE Access, where very surprisingly, it became my most cited paper, #1 with a bullet, where it's important for us to understand that AI encompasses machine learning, encompasses deep learning, which is the flavor of the month. Don't forget, there are other methods that I have just described that were used previously that are useful for small data sets, whereas deep learning makes use of huge data sets that are by themselves flawed conceptually. We'll come to that in a minute. So this is my lecture that I gave in the 2019 Royal College of Radiologists Middle Miss lecture, where the focus was on errors and preventing errors. Is it that artificial intelligence will come to our rescue? So I will rehash a few of the points that I made in that talk, which I think are relevant. So of course, being quite pretentious, I tried to link a quotation from one of the most famous books, that if you have a man in possession of a good fortune, you must be wanting a wife. Likewise, direct corollary is that if you're a radiologist, if you possessed artificial intelligence, you want a use case. So what is the use case? Is it going to replace us to make the diagnosis without any human input? Or is it for other purposes that we can even make a better and bigger impact on our care? So the computer vision use cases, not just the shopping or the algorithm of the social media contact and outrage, but computer vision. We have, as radiologists, been focusing on detection, segmentation, measurement, classification, and to a certain extent, radiomics in the dawn of its study. But don't forget, as the previous speaker has very ably put, image reconstruction, noise reduction, quality assurance is even more important. And what happens under the hood, so to speak, in the scanner room, which is invisible to us as radiologists interacting with the image at the final analysis, is even more important. There's also the problem of triage, and accurate, quick triage of the workflow can benefit from selecting those that are abnormal and important, the high stakes red bordered images, to rearrange the prioritized work queue to enable better, faster, more accurate, and patient-centric, patient safety-driven care, rather than first come, first serve. You never know where the abnormality is until you miss it, and there's a lawsuit. So if certain things can be prioritized by workflow and artificial intelligence, why not? So predictive analytics in business intelligence was also the subject of research by our colleagues, Dr. Chong Leroy in Changi Hospital, where not deep learning, but other AI tools can be used to predict those cases that may have in the past or may in the future be recalcitrant or for some reason be no-shows. These were reminded by telephone, and this resulted in an absolute decrease in the no-shows and relative improvement from baseline. So these are other areas that are non-interpretive for radiologists to use. So we need to ask the right question of AI, because if you have a fortune, you want to spend it wisely, and you want to find the right girl like in Sense and Sensibilities. If AI is the answer, then what is the question? The Royal College of Radiologists also put out a statement saying that, yes, we agree AI will improve, but it's very oversimplified, that it's going to make everything better. And it's very misleading for us to believe that it will solve all of our problems, but it will not be a magic bullet. So the non-interpretive AI for radiation protection, what does that mean? So to have a counterpoint to the wonderful pictures and literature that was presented earlier, we'd go back to the guiding principle of X-rays, CTs, and PET. The ALARA principle, as low as reasonably achievable, the use of time, distance, and shielding, these are tried and tested methodologies, but we can focus, now we have this wonderful tool, in the decrease of dose. Not to forget, in the bigger picture, radiation protection for staff and workers, protective clothing, dosimeters, and preventing interventional radiologists from having a heavy right foot. These are all other aspects of radiation protection that are important. Within our literature, this is an article which is deserving of notice, where non-interpretive AI can affect some of those that I've talked about, but also others, including radiation safety. Here, the authors talked about dose reduction, noise reduction, which makes us see better, have higher confidence, and decrease the retake rates and the non-diagnostic studies, which leads us to make a wishy-washy report. We can reduce artifacts, which gives us, again, better confidence. Patient positioning can be automated. Image registration can also be automated. And decision support, protocoling, work list prioritization, and scheduling can also be beneficiaries, not just in the area of dose reduction, but general patient safety. Radiotherapy, in this article in Radio Protection, using organ contouring, predicting the dose distribution and epidemiology. What about nuclear medicine, radionuclide detection, identification, not just in medical radionuclide, but also in disasters and in leakage. And finally, regulatory monitoring of dosimetry, databases, guessing which of your department's staff are going to be more vulnerable based on past track record, and tightening up processes as they happen. So the AI wish list from the radiologist's point of view is we try not to have fear. Let's play the machine's strengths so that we can play our human strengths. One of the wish lists is we want to have all the repetitive drudge tasks removed from us so that we can facilitate and augment the human expert. This includes registering, counting lesions, segmentation, and all those tasks that compare priors. We wish that this could be automated and can be done faster and better. For those that need sensors and AI to alert us to which are the cases that we must pay attention to. And then finally, the radiomics and invisible complex relationships beyond the naked human eye. Maybe we can extract characterization for human decision. However, all this is not rosy. And since my previous publication of my review article, very few of these have come on stream for us to play with and to enjoy. There are limits and challenges to what can be done in the regulatory as well as the ethical acceptance by users of AI under the hood. Here, an article from your moderator, Prof. Ng, and his group have spelled out very nicely that translation from science and engineering to clinical implementation and then finding out the financial and societal impacts is a very long process. The current challenges include ethical and legal, fair and trustable and we've all heard about bias, transparency, data governance, saliency maps that are unexplainable black boxes. So the trust and the patient's privacy issues are not yet fully worked out to our satisfaction. One other thing that gives me anxiety is the concept of quantum noise, where if you reduce the dose until low contrast lesions are no longer detectable in small lesions, what then? Well, it turns out that hopefully photon counting detector may come to our rescue, and it could be a very powerful combination with PCD plus AI. The hype cycle is moving up and down. A few years ago, we all thought we were going to get replaced. And then the cycle now is, oh, it's never going to come. So it will come again and again. And we are reaching the limits of the mathematics of deep learning convolutional neural networks. We need the next jump in mathematics to translate into the engineering. Whilst it is going through that hype cycle, it's important for us to remember that there are unintended consequences of machine learning in medicine. These are some dangers in de-skilling of physicians. Our clinical colleagues are already being accused of blindly ordering too many tests, which has the counterintuitive result of producing too many CT studies that will make us increase the risk of harm from radiation. Other problems are in the inherent uncertainty in medicine that blinds us to go for 100% certainty, ordering more and more and more unnecessary tests. These are philosophical problems that we need to face. I highlighted justification and alternatives to ionizing radiation, as well as decision support, because the guidelines on ordering CTs and MRs for headache, what if a study is not justified? It is better to have 0 CVITs and not have to do an unnecessary study. So this is coming under a lot of scrutiny, both in Singapore as well as the rest of the world. We've heard about image wisely and image gently. One, to do with general radiation safety and appropriateness. The other, specifically for children and the pediatric population. During the recent COVID shutdown in China, the surprising iodinated contrast shortage led RSNA to release a statement. But at the same time, the ISMRM also put in a statement saying that in some instances, if you don't have contrast media for a CT, why not try MRI? 0 CVITs. So beyond radiation protection and dose reduction, safety is broad. We need to consider more than during the imaging process. We need to consider before. Is it even necessary? During and after. Do we have a quality and safety ethos? Do we have a system that helps us to prevent other errors and other unsafe practices from staffing shortages, radiologist fatigue, eye strain, etc. And of course, all departments that are fully functional should have a monitoring and retake rates analysis. So as a radiologist team leader, not just a practicing cog in the machine, radiologists ask ourselves, how do we set the tones? How do we tell the radiographers and the nurses, how do we set the tone of maybe we should not be doing this study, which is unnecessary? During the pandemic, we also had to show leadership. Personal protective equipment, PPE, is not just for germs, it's also for radiation. How do we set the tone for patients? The public dose awareness and social media has made an impact, maybe not so much in Asia, but in the West, there is conversation going on about whether studies can be harmful and whether they are necessary. What do I engage with the vendors? There are some very well-known vendors who have got good tools. Let's encourage them and show our scientists the wish list for compressed sensing type of dose reduction, reconstruction. We may not need to understand them, but we can certainly use those tools. The redux is machines in radiology can help us develop better humanity in radiology. We should focus for the benefit of humanity in our work so that we can be free not to worry about all these problems. Because AI isn't just the most important threat on the horizon, because radiologists have a long history of automation, faster processing, functional MRI, smart calculations, radiomics. We always want to be faster, stronger, clearer, and of course, cheaper. With the new mathematics beyond neural networks, with sensors, hopefully we will get better sensors, which are not much talked about, and hopefully we will have better business intelligence. Our PACS dashboards can be very helpful for us to have better radiation and patient safety. Radiologists have always adapted, always changed with the times. We moved from alternators to PACS. Although the AI tempo of change is very much faster, these are disruptions in all of the business and clinical aspects. And it's not just AI, it's industrialization, it's commoditization, and it's turf war. So to go back to reducing radiology errors, is it AI to the rescue? To radiation safety, is it AI to the rescue? We live in interesting times, and it was the best of times and the worst of times. To recap, radiologists work beyond AI image interpretation, beyond the hysteria and the fear that we had previously. We can leverage AI to have radiation protection, exposure, dose limitations, all aspects of safety, and widen our perspective for a summary of what we can do for our patients. So my thanks to all the collaborators who have helped me along the way. Shameless advertising for next year. The AOCNR will be coming to Singapore with the SGCR wires in August. So watch out for the news and the publicity. So thanks very much. I am now going to hand the time back to Prof. Ng, your moderator. Thank you.
Thank you very much, Prof. Tchoyoson Lim. Wow, that is, you brought us down to reality. This is what's happening in clinics and hospitals, and that is good to know, right? A very balanced view in the midst of all the hypes of AI. Before we go to the Q&A session, just to remind the audience, listeners, to fill in the feedback form and the chat box in order to obtain your certificate of attendance. And do send in your questions to the chat box, and we will try to engage with you in the Q&A, your comments and suggestions. Like Dr. Ho is still with us, and Prof. Tchoyoson Lim as well. Okay, let's see. Question.
May I start, Prof. Ng?
Yes, please start, Dr. Ho.
Yeah, I definitely very good speakers showing us the full range. But in particular, I think the applications for most of us who are viewing, who are not medical physicists and so technically inclined, would be some of the things that Tchoyoson brought up. I think the most important thing is do not use. But you have one very interesting little phrase called dirty data. And I think it would be good for all of us to understand exactly what Tchoyoson means by dirty data.
So, okay. The data that you feed into the machine is very vitally important. So dirty data actually means two things. One is impure data, the other one is biased data. What does that mean? Because deep learning is learning on data, and is presupposed that if you give it large enough data set, if you train it on 100 pictures, it will get a pretty accurate picture. If you feed it 1,000, you'll get better. You feed it more, it gets better up to a certain point. Now, that data is assumed to be clean. This is not exactly true in all instances. So in many of the early studies that were published, some of the data ground truth was in the reports. And we know that the reports are not as accurate as other data that you can use. For instance, discharge data and pathology data, cause of death data. Some of those other data are more pure, but harder to come by. So the data provenance, how reliable it is based on what kind of gold standard is a question mark. That's number one. Number two is even if you do your best and you succeed in making all the data perfect, pure, and good, it isn't representative of a full population. So in the US, there's a lot of diversity and inclusion initiatives. Underrepresented minorities have a problem. And we know that Gillick and Pyle, the Bone Age that we all know and love, was of a very limited view of suburban, white, middle-class children, which may not translate to some of, let's say in Singapore, we were using that Gillick and Pyle to look at and compare with the wrist x-rays of Bangladeshi foreign nationals who might be working underaged in Singapore. So some of the assumptions may not hold true. So that's one way of answering it. Two parts. Dirty data is either incomplete, impure, or biased. So we have to be very, very careful about our assumptions. And we have to go back to the first principles. I hope that answers part of the question. Thank you.
Yeah,
very
thank you.
good.
Yeah, thank you. There's one question coming from Thailand, Dr. Chamari. She's an AOSR Honorary Secretary. She asked, should we train our residents to use AI, especially in interpretation at their first year of training, or should we do it later?
Thank you, Dr. Lim. That's a very, very excellent
Dr. Chamari.
lecture. Although a lot around the interpretation, but I have concern on one thing that you say, that AI may make physician skill worse, right? And one part of that is also our resident. I'm not sure that, I mean, digital literacy of this young generation is very good, but I don't know, should we go back to basic in terms of train them later so they can use old style of learning before using the AI to help them? But what is your opinion on that? Thank you.
Right, okay. Yeah, the answer to this is there's no answer. It's just an opinion. So in my opinion, the state of AI tools today is not good enough to train the first-year residents. I think they will have to go back to the basics and master the basics first, and then maybe in their third year. Because my own experience, I have a small project on asking the residents to classify a brain tumor and then giving them the AI prediction of the brain tumor and ask them whether they're going to change their mind. So it's like those Who Wants to Be a Millionaire kind of quiz show, you know, they shake your confidence, see whether you will stand by your first guess or not, right? So I think it's more nuanced because we're never going to reach 100% sensitivity and specificity, not for humans, not for AIs. We still need to have that discussion. And I think that's a higher order learning skill set that is best taught, maybe in third year, fourth year, maybe even fifth year. I'm not sure. So that's just an opinion. That's just me. Thank you.
Thank you. For your comment, Lim. Any other questions? Meanwhile, I would like to ask, you recall we used to have this computer-aided diagnosis and then computer-aided detection, CADX, particularly for memo. That's where I have some experience, but somehow that didn't catch on. Do you think with this deep learning, there will be a revival, enhancement of such system?
Well, That's a very good question. And in the discussions that I participated in, there were many radiologists who said, CAT came for breast mammography. It failed disastrously. Nobody uses it. And therefore, we can expect AI not to make any dent on our practice. Don't worry about it. Go back to sleep. So I think that's a little bit too optimistic, because there are good things that can come from the performance of some of these classification tools. Now, the reasons are manifold, but the counterpoint to that is that if the bad experience, especially from dinosaurs like me, who remember how bad CAD was for mammograms, it might put us off using some of these tools. And I've started to change my opinion over the past 4 to 5 years, because the sheer volume of requests and the number of studies that we're doing now is unsustainable. When maybe just 10 years ago, a study for MRI was about 200 images all in, pre and post contrast, everything. Now 3D reconstruction can overwhelm you with 1,000 images easy. My eyes are extremely tired. Now it's 8+, I can barely look at the screen now, right? And so my useful life as a radiologist is being cut short, because, all of these things are going to tell on some of our younger individuals. Well, of course, if you are a, 26-year-old Sierra Hotel radiologist, you can blitz through 6,000 images and, still go rock climbing and go dancing after work, right? But as you get older, the cognition is going to have to mark up to go with this. So I think we need tools. We need good tools. We just don't want the CAD tools. We just need to make the vendors give us better tools. As to where they are, I really don't know. So, I'd be interested to hear your points of view as well.
I have to add here that CAD in memo in the original was really terrible. It just wasted our time so much. But I've seen the latest applications for AI and reviewed it. And it works differently. It helps to triage. So you look at the important things in the beginning, and it also tells you there is a possibility that this is dangerous. So when it tells you that you might have something which is significant, say a 4 or 5 by rats category, then you open your eyes to look at it. So it's a little bit, and you can also, what is very important is you can also just dismiss by saying you do not want certain aspects of that AI application to help you. But really, I think if AI can really help us improve the workflow, draw in the clinical information, coordinate that for us, rather than me having to click, go into the medical information system, what is the real thing? Because as we know, until now, our clinicians are not helping us enough by giving us the relevant information so that we don't have to go and hunt for it. So AI needs to help us there. Once that helps us, it will help us. And AI also, I believe, needs to help us reduce the number of sequences for MR brain if needed. Just the essential based on clicking in. We think this patient may have ABC diagnosis. So give us the protocol that doesn't give us like 1 million sequences to look at. So this is where I think AI is needed to help us. We cannot keep looking at AI to help us interpret more accurately. The moment AI does that, that is when it replaces radiologists. You don't need a radiologist anymore if it can diagnose things with higher confidence level and higher accuracy than us. And I don't think that's going to come because humans are just too varied and interesting in their presentation. The fact that we have so much normal variation. So AI, and as you said, AI only learns from what we feed them. And right now, the fear is that most of these AI algorithms are not global. They're very much Western data, or depending on which country you are in, your own country data. So how are you going to apply any software that any vendor makes across the whole world? So I would rather focus on non-interpretive aspects of AI, as you have mentioned very well, how it can help us workflow, reduce our burnout, reduce our stress, make us practice more safely, reduce, not necessary. Tell the clinician, have AI said, not necessary for this do not do a chest X-ray just to screen someone to enter university, which is what Singapore has done very well. You have this clinical guidance for not applying chest X-rays unnecessary. So these are useful ways in which it can help us. Just to introduce Chamari, our honorary secretary from AOSR, her subspecialty interest is informatics. So in case anybody wants to ask, there's a question now actually.
Okay. Are you going to say something, Dr. Chamari?
No, thank you.
Okay, thank
for
you. Now we have 3 questions. Hope Tchoyoson, you could answer them briefly in view of the time. Why there are 3 questions coming in. The first one, may you expound more on radiomics and what is the future of using this in the clinical setting?
Okay, very briefly, radiomics talks about factors in the image which sometimes are not visible to the naked eye or are not processed by radiologists in our description of, let's say, a brain tumor. So radiomics is very highly used in brain tumors with things like texture and other factors, which we don't consider as important. So heterogeneity, the variability, and many of these other factors, they do have some biological meaning. We just haven't dug deep into the surface yet. So this may be an area which I think beyond the naked eye, so to speak, we should be able to get some information. Again, radiomics turns out not to have huge data sets because like the early work is in brain tumors, 40 cases per year in Singapore, very hard to come by data. So there are small data sets, but like I said, we can also use random forests and other methods apart from convolutional neural networks. So there's efforts to do that, but there are limitations. Until and unless we have huge data for radiomics, we won't use them. My Korean friends, so any of you using radiomics for real life? Not many, right? So it is also another promising and potential. Akan datang. Yeah, next question.
Thank you. Now, what is the impact on image quality using AI-based radiation dose reduction methods?
What is the impact? I don't know. I have, okay. So I remember the days where a CT scanner would do 1 revolution and then tube cooling. Then I can go and get coffee, 1 revolution and then tube cooling. I can change the plate for the printing of the film. So now it moved to a spiral, and then the spiral has kernel reconstructions that are multiple. We've got dual energy. We've got a whole bunch of stuff. And you know, the photon counting thing starts to sound really, really interesting. So all of these things are what I consider things that go on under the hood. So when I drive the car, I don't know what the alternator is, and I don't know what the spark plugs are, but it moves lah. So I'm hoping that the reconstruction dose reduction will do the same thing. We'll let the smart physicists and mathematicians like Prof figure that out and then show us. And some of the vendors have been putting very persuasive pictures of non-inferiority with low-dose images. Now, if I can trust them and I can see them, compare them to my past record, that is kind of an old fuddy-duddy way of approaching things, but it gives me better confidence when I say that, you know, this newer low-dose reconstruction is better in XYZ. If the spiral or the other reconstruction algorithm is actually worse and I don't like to see it. Because remember, once you've acquired it, sometimes it's very hard to go back and change, right? Or you have to reshoot. The retake rate, I think, is also a factor that we haven't yet considered. So I would like to see changes being made. And like I said, we've always dealt with changes, right? There's no way I'm going to say, hey, I like that old, you know, high dose method better. For Tchoyoson Lim's CT scans, only use that method and nothing else, right? Nobody will, you know, the head of department will call me up to his office, right? So the radiation safety for this will trend in one direction. We just have to adjust our minds to interpret based on what we're given. And track record is we have been getting better and better. So, you know, kudos to the physicists who work really, really hard on this. I think that will be a game changer, but it will be a very gradual and unnoticed, which is good, right? That, you don't notice that good things are happening. Yeah, back to you.
Okay, thank you. The last question, interesting question. How to convince people about the benefits of AI for this course in developing countries, as cost is a major factor here?
Okay. I'm not sure I understand the question. To convince who? To convince the user?
I think the public
patient?
or taxpayer, perhaps, to invest in AI. It
Oh.
costs a lot, yeah. So how to convince that benefit investing so much money in AI in developing countries?
Let me give you a different perspective of that question if I understand it right. The problem with many of these AI vendors, it is an add-on and you pay. It's not like a big vendor like Siemens, and they have integrated like these iterations or algorithms to use lower radiation dose and get good images. That is part of the newer CT scan that you're going to get. So you do not see that in inverted cost as an add-on. But today there's, for example, a chest X-ray. It is an add-on cost to apply the AI to your regular chest X-rays that comes in from ER, let's say, on all that. So I think that's what the question is asking. How do you justify the cost?
I couldn't put it better. I would only go to venture 2 points. One is that, how advertising, when you buy a new computer, sometimes you see the sticker, Intel Inside, right? The guys who make the chips. Yeah. When I buy the new CT scanner, I would like to say AI Inside. It will be hidden under the hood, right? And the other thing that we take for granted with new and better and improved models is, if you drive a Lexus 10 years ago, and now 10 years later, your Lexus is hybrid. So you're feeling good about saving the planet. So you will get the AI as a matter of course, because it's in the company's vendors' interest to give you the best. Of course, they make you pay more and more, but that is a function of inflation and stuff that are beyond our control. But we're hoping that more and more becomes standard. For developing nations, it's going to be very hard, but there are also other initiatives where if you have AI, it may help some of the third world countries progress a bit faster than they would if they didn't have it. Not just in terms of the equipment and the safety, but also in the training of radiologists. So that's the next frontier. I believe we should train our humans with deep learning, just like we train our machines with deep learning. But that's another topic for another day. Yeah, back to you, Prof.
Okay, thank you very much. I think with that, I'd like to thank both the speakers, Professor Habib Zaidi and Professor Tchoyoson Lim, for giving us these wonderful talks for this inaugural ASIASAFE AOSR IAEA webinar. I'd like to thank the participants staying on, asking very good questions. Remember, the recorded video will be available for next 2 weeks, and also fill in the feedback form if you wish to receive a certificate of attendance. Thank you once again. Have a good evening and enjoy the rest of the day. And we will have a second ASIASAFE AOSR IAEA webinar. We'll announce it through the AOSR channel communication. Okay, good night. Bye-bye.
Thank you, everyone.
Thank you, everybody.
Thank you.
Thank you, Prof.
Thank you, ma'am. Thank you, sir.
Offline?
Sir, I would like to make an announcement, sir. Dear delegates, to receive your certificates, kindly fill the feedback form. Please find the link for the feedback form in the announcements. Thank you. With your permission, may I end the session, ma'am? Thank you, ma'am.